I'm going to give you an overview of the current status of some colposcopy management guidelines, and to illustrate that I'm going to go through the Canadian guidelines which were published in December of 2012 and the American guidelines which were published earlier in 2013. These are the most recent guidelines, and they just illustrate some of the management principles that are out there in colposcopy. You have to remember that although we are two close countries in North America, we are very different in the way we manage things. And generally speaking, Hpv testing is not available widely in Canada, so we might have some high-risk Hpv testing that's available to us in the colposcopy clinic. Whereas in the US, they widely have Hpv testing available, and they increasingly have more testing and newer testing, including genotyping, available. So they've expanded their algorithms to be very complex and include genotyping in them. And as I go through this, and you'll get this in your syllabus later on, you'll actually see the differences between the two programs, and you can look at the algorithms online. So the American guideline meeting was held in 2012. There was 47 experts, of which myself, Mario, and Dr. Prendeville were part of, from 23 societies, national and international organizations. They used available international literature and data from the only managed healthcare plan in the US, the Kaiser Permanente, not the only managed, but one of the ones that gives the best data, the Kaiser Permanente Northern California healthcare plan. And they actually analysed the data from the women there and their risks of abnormal changes and dysplasia when they were managed in different ways. The basis of the recommendations was evidence-based, and it was based on equal management for equal risk. And they basically said if their risk of CIN3 was greater or equal to 5% over 5 years, they would recommend immediate colposcopy. If the risk of CIN3 over 5 years was about 2 to 5%, they would come back to colposcopy in 6 to 12 months. And if the risk was lower at 0.1 to 2%, they would have a 3-year return. If the risk was low and was comparable to a woman without a history of abnormality at about 0.1%, they would have a 5-year return. In Canada, we put our guidelines out in 2012, and we discussed things including the colposcopy exam. We adopted widely the new IFCPC terminology. We made some recommendations about biopsy and have suggested that when you see patients in colposcopy, particularly for low-grade lesions, you consider taking 2 biopsies based on the evidence from the ALTS trial, where 2 biopsies detected 81% of abnormalities of CIN2 or greater versus 68% if you just take 1 biopsy. Generally speaking, if there's some acetowhite change, you think it might just be metaplastic there. For a low-grade referral, you're going to take a biopsy just to make sure that you're not missing any high-grade finding. The Americans have recommended random biopsies, meaning that if you look at a cervix, you don't see anything there, you take a biopsy of the transformation zone at an area, you don't see it. We didn't feel that was generally necessary. And we also, based on some Canadian data that has been analysed by Americans, didn't feel that ECC was generally necessary. Dr. Satan and Nisrin worked in Calgary, and in Calgary they recommended ECC on everybody they saw in colposcopy. But they, on a review, they saw that they needed 99 ECCs, which is an uncomfortable procedure to be done to detect 1 additional case of high-grade dysplasia. And they only saw the benefit in older women with high-grade cytology. The other recommendation we made was that we didn't need to do Hpv testing on all women. What about, so you go through these algorithms, we'll start off with abnormal cytology. What about abnormal cytology in the younger woman less than 21 years old? This is a controversial issue. They shouldn't be screened. If you find it, we sort of suggested that they might need to have repeats versus referred to colposcopy versus repeats after 21 years. Eventually didn't come up with any particular guidelines because it should be done by the provincial guidelines, but we've discouraged doing a pap testing in young women. If they get a high-grade finding, they should be colposcoped. Another problem we have in Canada, which they don't have in the US, was wait times, and we've suggested that if you've got a high-grade finding like HSIL, you're seen in colposcopy within 4 weeks. If you've got ASK-H or AGC within 6 weeks, carcinoma within 2 weeks, and low-grade findings within 12 weeks. I must admit, in my clinic, we are not seeing our low-grade findings for up to 6 months after a receipt of referral, so that is a problem for us. The Americans came up with some guidelines about, the Americans' guidelines here all have the ASCCP logo in the bottom right-hand corner. Unsatisfactory cytology, so you take a pap test and it's unsatisfactory. They've broken that down on whether the HPV is unknown, in which case you repeat it after 2 to 6 months. If it is negative, again you repeat it after 2 to 6 months. If it's positive, they go to colposcopy or repeat again. So there's recommendations there about managing unsatisfactory cytology. If it's negative but insufficient sample, again they look at HPV negative and they go back to routine screening. In this older women over 30, if it's HPV is unknown, they suggest taking an HPV test. And these algorithms for the Americans get very complicated because they may or may not have HPV testing going on when they're doing it at the same time. Remembering that the Americans in the over 30 women are often recommending that they have colposcopy, sorry, they have HPV testing and a pap testing done at the same time. In Canada, whoa, okay. It didn't translate very well. Okay. So the spelling has gone off a little bit. I'm not that bad at some of it's okay up there. No, some is not very good. If they are high risk HPV positive and cytology negative less than 30 years of age, I think that's what that says, you repeat cytology at 12 months and manage it per cytology. At the present time in Canada we've not done a lot of work around that. If they are over 30, this is what Mario was just talking about, we've suggested that if they are positive and they're HPV positive and the cytology negative, you repeat the HPV testing at 12 months. And if it's HPV negative and colposcopy negative, cytology negative again, they return to screening. If they're positive, they go to colposcopy. If they're high-risk HPV positive and cytology, ascus or otherwise, they manage as per the cytology, but often they will be going to colposcopy. So this is the American guidelines for women who are over age 30, who are cytology negative but HPV positive. And this is what the group we're talking about. And the acceptable management is to repeat the co-testing at 1 year, which is acceptable, and then you go down at management on this side. And if they are negative and negative, they go repeat co-test at 3 years. So you can immediately go out to 3 years again. If they have anything to be found on the repeat co-testing, they get colposcopy performed. It is acceptable to do DNA typing, and this is testing essentially for genotyping 16 or 18, and there are tests out there that do this. And if they are positive, they go to colposcopy, so you've picked out a high-risk type. It might be more correct to actually include 31 in that, but and that is one of the issues that is in different parts of the world is very relevant. I do know in our Colpo clinic we see a lot of HPV 31 when we've looked at it. It's the second most common. About 30% of pap tests have HPV 31 in them that get dysplasia, but we just filter it out a little bit because we still have 20% or more of adenocarcinoma. So in Canada, jumping back across the north, across the border again, back to Canada, management of LSIL and ascus, we recommend repeating that, and we take them after 2 abnormalities before they come in. Unless reflex HPV testing is done, and some provinces do reflex HPV testing. You've got to remember when we do colposcopy, we are doing it to rule out high-grade dysplasia that is potentially pre-malignant. We've often said that is CIN 2 to 3, but it will probably move to just being CIN 3. The risk of getting CIN 2 plus is about 10% with ascus and 17% with LSIL. The risk of getting CIN 3 is about 6% with ascus and 12% with LSIL. So it's slightly higher with LSIL than it is ascus. However, when I've looked at it, if you've got LSIL, ascus, ascus, LSIL repeated before they come into colposcopy, the findings are around about the same. So when you see those patients, you're going to biopsy any lesion and consider a random biopsy, although that's very controversial. If negative, colpo biopsy with any transformation type, we've said there is discharge to annual cytology for 3 years and then go to every 3 years per provincial guidelines. We are slightly different to the Americans because we don't have a negative HPV thrown in there to give us that 3-year reassurance. So this is the algorithm for that actually came out, okay, which is the ALSUS or ASCUS or ASCUS HPV positive. They get colposcopy. If you don't find anything, they get screened in routinely. If they get colposcopy, they get CAN1. Or if they find CA1 or greater, we manage that according to the histology management guidelines. Well, I'll give you the website where you can get on as well, all the guidelines. The US, this is the management of ASCUS on cytology. It is preferred that our HPV testing is done, and if they're HPV negative, the repeat co-test at 3 years is done. Their risk for that of CAN3 or greater is about 0.54%. It's lower than 5%, lower than 1%. Hence, you can go to every 3 years, sorry. If you repeat cytology is negative, they go back to routine screening. If they've got ASCUS or greater, they get colposcopy. So a similar sort of algorithm. They do have an algorithm that goes for young women less than 21, and they talk about doing HPV testing in the younger women and repeat cytology, and they go through this complicated algorithm. I'm going to slip over that one. This is the women with LCIL changes, and because they do all this co-testing, it gets very complicated. You know, you can have an LCIL pap test that's HPV negative, an LCIL with no HPV, or an LCIL that's positive. The only one that gets repeated at a year's time or gets deferred for a while is a negative HPV test. But then you repeat both of them at a year's time. If they're both negative, they can get a pap test done in 3 years. If they are positive on ASCUS or HPV positive at the repeat, they get to colposcopy, and then you manage according to what you find at colposcopy. So that gets quite complicated in the American algorithms. Pregnant women with LCIL. It used to be that a lot of pap testing, opportunistic pap testing, was done during pregnancy, so you would find a lot of abnormalities during pregnancy. But realistically, we're not going to treat people in pregnancy unless we find a cancer there. And treating abnormal cells in pregnancy just causes anxiety. But if you have pregnant women with LCIL, they have suggested that you do colposcopy. If they have no CAN2 to 3, they get postpartum follow-up. If they have CAN2 to 3, they manage according to the guidelines, and they have guidelines for that. Most places would actually either just see the patient, make sure there's nothing obvious there, and then see the patient after pregnancy. The other option is to defer colposcopy until about 6 weeks postpartum, which is more accepted management. Back to Canada again. ASK-H is a higher grade pap test, and in Canadian review they had high grade displays of CAN2 or greater in 70% of findings, and they had a carcinoma in 2.9%. So women need colposcopy with an ASK-H pap test. So what we've suggested here is that you get colposcopy. If you find dysplasia, you get managed accordingly. If there's no dysplasia, you repeat it at 6 months' time, perhaps using an HPV test that's available to you to reassure yourself. If you don't find anything, you get returned to screening. If you find something, you follow them, and if you find some dysplasia, you treat them accordingly. So that's ASK-H. This is the American guidelines for ASK-H, and you do colposcopy on them again. The Americans came up with a slightly more complicated algorithm for the younger women, and hopefully you'll never get into this, because if you don't start screening young women, you won't get into this problem of having to avoid damaging the cervix and causing preterm delivery. But they sort of talked about, if you've got young women who have high-grade findings, either ASK-H or HSIL, you do colposcopy. It's unacceptable to do an immediate loop procedure. If you find CAN2 to 3, you manage accordingly, and there's a guideline to look at that, and we'll get to that later. If you don't find anything, you can observe them in colposcopy and cytology, with colposcopy and cytology at 6-month intervals, and then if you get 2 negatives, they go back to routine screening. If they get anything else, they get found, they get watched in the clinic. So this gets a complicated algorithm for the young women. We didn't have quite as complicated an algorithm. For management of HSIL in Canada, you get a lot of high-grade changes. If biopsies are performed, it's 50 to 66%. And you need prompt colposcopy, you need biopsies. We generally do biopsies before we treat. I know Walter does a lot of immediate treatment when he sees these patients. And you do an ECC particularly in an older woman, and if it's a type 3 transformation zone, or i.e. the transformation zone is not seen in its entirety. The areas of concern are high-grade findings in a young woman and the difference in the management there, and HSIL in an older woman when the transformation zone is not seen in its entirety. They should have an appropriate excision performed. So this is the algorithm that we've got for this, which is HSIL gets colposcopy with biopsy plus or minus ECC depending on the age, etc. If you find CIN2 or greater, you treat that appropriately. If you don't find it, if it's satisfactory, you can observe that patient to colposcopy, seeing them every 6 months for 2 visits, and if things are negative, they can go return to the screening protocol and annual cytology for a while before going to every 3 years. If it's unsatisfactory, i.e. they have I shouldn't use the term unsatisfactory, we're not using that anymore, but this is in an overlap period between the new nomenclature and the old nomenclature. The type 3 transformation zone, they should have a review of the cytology and histology. If there's any findings there, you treat appropriately. If there's concern about high-grade findings with an HSIL pap test that you missed on colposcopy, you need to do an excisional procedure or a type 3 excision to investigate further. So the Americans, for older women over 24, immediate loop, for high-grade lesions, immediate loop or colposcopy. If you don't find anything, you manage accordingly. But hopefully everybody's getting colposcopy to guide the management. That's my one fear about the Americans. If you sort of say, oh, you do immediate loop, they might not even look at the cervix colposcopically. They might just go ahead and do a loop on the cervix, and that would cause more problems. So everybody with HSIL should have colposcopy to direct a biopsy, to direct a treatment, whether it be done immediately or later. Management of glandular findings. This is a rare pap test abnormality and causes patients a lot of and physicians a lot of concern in Canada, I know. Nearly every gynecologist I know has had problems in management an abnormal glandular pap test, and patients have shown up with cancer later on, and they've been followed for a while. In a Canadian review of 450 cases, 7% had low-grade findings of CIN. The highest proportion had high-grade CIN, and there was some adenocarcinoma of the cervix, there was cancer of the cervix, but in 30% there was endometrial pathology. So quite often with an abnormal glandular pap test you'll find an endometrial cancer. So you have to look and see what the patient is coming for. If they've got bleeding, if they're older, they need an endometrial biopsy. So you need to adequately assess the patient, you need appropriate cervical curettage, endometrial biopsy. And there are 2 categories of pap test that are thrown in with an AGC pap test. It's an AGC NOS or not otherwise specified, where the cytologist there's something going on but they're not able to call exactly what it is. And there's AGC N, which is favored neoplasia, in which case they think there is a potential malignant finding. You should treat that patient appropriately. So this is our algorithm in Canada for this, and this is the roadmap to put everything on one slide, and it gets very complicated. But if you have an abnormal glandular cell that's endometrial, you do a biopsy, you manage that endometrial biopsy. If you don't find that, you get colposcopy, which is the same as the not otherwise specified. If you find CIN, you treat it appropriately. If you find adenocarcinoma in situ, you treat it appropriately. If you don't find anything, how long do you keep an eye on these patients? And I've had patients in my clinic that I've seen every 6 months, without Hpv testing, every 6 months for 4 visits, and on the last visit I found a little bit of glandular precancerous changes. And that is not uncommon to find that. And then you treat the patient then. So you can follow patients, and Hpv testing gives you some reassurance, because there'll be patients that get a glandular pap test, are HPV negative, and it may just be endometriosis or some tubal metaplasia or that's causing the problem that you're seeing. If you've got AGC favored neoplasia in the colposcopy biopsy, if they've got a cancer there, you manage that appropriately. If they don't find anything with your colposcopy, ECC, and endometrial biopsy, they need a diagnostic excisional procedure or a type 3 excision of the transformation zone. And I would argue it doesn't matter how you do that, whether you do a cold knife cone or whether you do a large loop excision of the transformation zone or you do a needle excision of the transformation zone, it doesn't matter. And then you manage that accordingly. The Americans simplified theirs, but there are some other findings there. And then there's a subsequent management of in the American algorithms. Very similar to the Canadian algorithms. So that's how you manage cytology. I'm going to move on to managing histology. CIN1, the low-grade findings, and CIN1 and HPV are very difficult to distinguish and separate. This seldom progresses to cancer. Regression occurs in most women between 60 to 80% of the time within 2 to 5 years, and there's several papers where it's got up to 90% in younger women. So the question has been, if you're not going to treat these people, where should you observe them? Should they be kept in the Colposcopy clinic, or can they go back to their primary healthcare provider? And I know that might be different for yourselves, but in Canada the way we do it is to send them back to the family doctor for that. So this is what the patient, if the patient has CIN1 or biopsy or cervical curettage, if the colposcopy is a type 1 or type 2 transformation zone, you can observe those patients with cytology at 12 months, repeat that for a couple of times, and then if it's all negative, they go back to every 3 years. If it's unsatisfactory colposcopy, i.e. a type 3 transformation zone, we've suggested that they get kept in the colposcopy clinic, and this is a minority of these patients. If it's negative and it's gone away, they can go back to screening on a regular basis. If it persists or progresses, they get treated. If I see a 45-year-old woman with CIN1 and it's there on 2 visits, I may well just treat that patient to avoid them coming back, because I'm not going to do any harm by doing that, or unlikely to do harm. If they have CIN1 after high-grade findings or an AGC pap test, you might want to consider doing a excisional procedure or type 3 excision to make sure you're not missing something that you've not detected, because there was a higher grade pap test there preceding it. So management of women with no lesions or CIN1, and this is the American recommendations. They would recommend follow-up without treatment and then co-testing at 12 months. If both are negative, they can get back to screening, which is either 3 years later. And so there's a complicated algorithm about that. So that's the American algorithms for that. And this is for the CIN1 preceded by an ASK-H pap test or HSIL cytology, which is you can do one of all 3 of these things, whether you do co-testing at 12 and 24 months, an excisional procedure, or review and manage accordingly. And this is young women. Again, they have lots and lots of algorithms in the American set of this, and it does get complicated. High-grade findings. We have asked our pathologists to clarify whether it's CIN2 or CIN3, and we have asked them to use P16 to help, especially in the women less than 25. In the women 25 and older, if you have CIN3, it has a malignant potential of about 30% over 31 years. This was based on a study of an unfortunate study that was done in New Zealand, where they decided not to treat people who had CIN3. So you usually prefer treatment, and we prefer treatment with excision for CIN3, and you can see this dense acetyl-white change here on the cervix with the IUD strings. So CIN2 and 3 in women over 25, if they've got satisfactory colposcopy type 1 or type 2 transformation zone, they get treated. If they've got a type 3 transformation zone, they get treated, but your treatment is tailored to the transformation zone that you're seeing. So you're going to take more cervix for a type 3 transformation zone. This is the American guidelines, and if they talk about adequate colposcopy, they haven't yet adopted the IFCPC terminology. And it just it's not quite as clear as using transformation zone type. They suggest that excision or ablation, i.e. cryotherapy or laser ablation, is acceptable. Ablation is not used widely in many cases. If it is inadequate or they need an excisional procedure, essentially this is the type 3 transformation zone. In the younger woman, CIN2, we have suggested that we observe these women. So if we detect CIN2 in women that are reliable, they're going to come back and see us, and they haven't had their children yet, we are going to often observe those patients and see whether it's going to regress. There's several studies where regression occurs at least 40% and up to 62% over an 8-month period. So we can try to clarify if it's CAN2 versus 3. I'm not convinced myself whether there truly is a difference between those, whether true CAN3, true CAN2 that's going to cause a problem is probably the same as CAN3. We observe them in clinic. So this is the algorithm we use for that. So if it's CAN2, observe them in clinic for up to 2 years, resolves, goes away, they get screened routinely. If it persists or progresses, they get treatment. If they've got CAN3, you do treat the same way as we did before. This is the American guidelines, and they've talked about young women and they haven't put an age limit on it, but it's about essentially the same sort of guideline. It's there. Remember, when you're doing excision types, you need to remove a lesion, and you tailor your treatment to the lesion type. Type 1 transformation zone requires a shallow excision, and a type 3 requires a full cone or type 3 excision. And the new nomenclature was brought in to reduce the confusion. And this is a schematic of the transformation zone types with the type 1, type 2, and a type 3 transformation zone. Glandular findings. You need to perform an adequate excision, which usually should be about 20 millimeters, not 20 centimeters long, and you could consider a hysterectomy once you've done that to rule out cancer if childbearing is complete. However, we see a lot of women that get a leap for CIN, and then on the specimen, when you go to the lab, they see AIS in association with the CIN. And in that situation, you don't need to do a repeat excision for those patients if the margins are negative. This is an area here with a big gland opening and some fusion of the villi and some acetyl white within the transformation zone that actually had this AIS on it. So if you have AIS on biopsy, they need a type 3 excision of the transformation zone or a diagnostic excision procedure. If the margins are positive, preferred option is to repeat the procedure and then perhaps go on to hysterectomy if childbearing is complete. It is acceptable to observe those patients, but most people we would prefer to repeat the excision. If they have negative margins, you can consider hysterectomy if childbearing is complete, or it is acceptable to observe them. And I receive them in my clinic for up to 5 years before returning them to a screening. And this is the same sort of management from the US. Follow-up post-treatment. A lot of people have seen people, they've treated them, and then they follow them up, and they keep them in the clinic for a long time in follow-up. Around the world, everybody is growing to accept that HPV testing as a test of cure is a great test to use, whether you do that at 6 months, 12 months, or you do it at both visits. It's not yet totally been sorted out. There's a randomized controlled trial coming from Canada that will be published. The results will be out in about a year and a bit. So what we would suggest you either do is conventionally, which is follow up at 6 and 12 months with colposcopy and cytology, or follow up at 6 months with cytology and high-risk HPV testing. If those are negative, you can go to screening protocol. If you find some CIN, you treat again. And this is in reference to our next talk, which is about pathology and how you talk about the L-cell and H-cell, and so the L-cell, if it's called, in the last new terminology, if it's called, histology is called L-cell, you manage like CN1. If it's H-cell, you manage like CN2 and 3, and that's where we sometimes ask people to differentiate. So the ASCCP guidelines are available as on an app for your iPhone and for your Android phone. So if you want to something have in your pocket and you're in clinic and you want to go through the algorithms, and you can do it on a touchpad basis, it costs you $10, but they're available via the ASCCP website or on the app stores. You just search for ASCCP. And these algorithms are available via the Canadian website, colposcopycanada.org, via the American website, the ASCCP.org, and links from the International Federation website, ifcpc.org. So all these algorithms are there and worthwhile having in your office, particularly if you don't see patients on a regular basis. You have a source to go to, and your management will be sound when you do that. And finally, come and see us in London and join us for the IFCPC. Thank you very much.